Hello, welcome to our special live streaming series, COVID-19 Frontline on CGTN. I'm Zoyin. COVID-19 Frontline, the special online live show for experts from not only here in China, but also around the world to share their expertise and experience in the prevention, control, diagnose, and also treatment of COVID-19. And apart from expert discussions, we also take questions from our followers on a variety of different social platforms, such as CGTN app, the official website, and also CGTN official account on YouTube, Twitter, Sina Weibo, and more. So feel free to leave your comments and questions with us. And we do leave them. Do remember to use the hashtag #MyOpinion of COVID-19. And also, today we have experts from China, the United States, and Canada joining us. And they are, first of all, let me introduce all of them. They are, first of all, Dr. Pan Aijun, who's the Chief Physician and ICU of First Affiliated Hospital of the University of Science and Technology of China. Welcome, Dr. Pan. And also Dr. Wei Wei, who's the Chief Physician of Department of Radiology of the First Affiliated Hospital of the University of Science and Technology of China. Thank you so much for joining us, Dr. Wei. And also Dr. Fu Binqing, who's the Professor of Immunology of USTC, which is on the same university that we just talked about. And also Dr. Shang You, who's the Director of Critical Care Medicine Department of Wuhan Jinyintan Hospital. And also, he's the Chief Physician of Department of Critical Care Medicine of Union Hospital, affiliated to Tongji Medical College of Huazhong University of Science and Technology. Thank you so much for joining us, Dr. Shang. And also, last but not least, we have Professor Qin Ximing, who's the Associate Professor of Environment and Health Sciences of Anhui University. So thank you so much for joining us for our Chinese experts. We also have 4 international medical experts from Canada and the United States, and they are, first of all, Dr. Robert Cruz, who's the clinical pathologist at Johns Hopkins Hospital. So thank you for joining us, Dr. Cruz, and also Mr. Saeed Babay, who's the chairman and CEO of Verotech from Canada. Thank you, sir, for joining us. And Dr. Rakesh Arora, who's the head of cardiac surgery and cardiovascular ICU at the University of Manitoba. And also Dr. Chris Tadulo, who's the university head and medical director at Winnipeg Regional Health Authority. So thank you so much for joining us, ladies and gentlemen. And without further ado, let's just start our discussion. How about we start from Mr. Babay, right? So do you have any questions for our experts from China?
Sure, absolutely. Thank you for the opportunity and a pleasure meeting all the panelists. So we have 2 topics to be discussed during this discussion. And the first one, we want to sort of get experiences surrounding cytokine storm, that what is this about, who's most susceptible, to this condition, and what are the options moving forward in terms of, having any treatment or mitigation strategy for cytokine storm. So on that, maybe I'll just give maybe a 30 seconds sort of my thoughts, and then have the panelists, whoever wants to step in and share their experiences, how they see this in the clinic, and what strategies they're taking to overcome that. So just my sort of a brief introduction on that. The term cytokine storm is relatively new in the sort of the medical practice, first reported in 1993 in the context of a graft versus host disease. And the context became more kind of, appearing in the literature and the discussions after the avian H5 and N1 influenza back in 2005 with the bird flu, during SARS, and very much of an important criteria or context in COVID-19. One of the sort of the molecular mechanisms for the cytokine induction or storm induction is a very complex, but one of them is associated with a receptor called toll-like receptor, specifically with TLR1, and is basically the genetic variation of the patients in the form of a single nucleotide polymorphism that it gives it that complexity depending on your SNP's pattern, how you're going to really respond to such a profound insult like COVID-19 virus. So that really will determine the hyper or hypoimmunity to an insult that is posed to COVID-19 patients. And just to continue on that thought, Some of the treatment strategies has to do with immunomodulations. Drugs is out there. The examples are Cytokine receptor antagonists. I know people have used statins, anti-TNF agents, as well as OX40. And the complexity is exactly the precise timing that any immunomodulation can be utilized to get an optimal effect in the patients. So in the onset, you don't want to play around with immunosuppressant. You want the immune system to be very much activated. So you sort of have to let that be. But in the matter of the few hours when this immune system is highly elevated, then that's the window that the clinicians and the caregivers that have to really be mindful of using some of these immunomodulations. And we do know that there's a great amount of work with the IL-6 antibody coming out of China, very promising results. But interleukin-6 is really one cytokine. Obviously, there's a more whole slew of cytokines, such as other interleukins, and TNF-alpha is important. So I want to open up to the panel just to sort of get your opinion on the best practices and how prevalent cytokine storm is with the patients that you see in China, and to the colleagues in Canada and the US as well.
So I think, I think I can answer your question. I prepare a slides. Maybe I can show you right now. Okay.
Sure, that would be great.
Yes, thank you, Dr. Fu.
Okay, can you see this?
Yes.
Yes.
Yeah.
Okay. I'm very honored to introduce our tocilizumab treatment to reduce mortality in this severe COVID-19. And we have previously, Professor Hemingway's group have identified that there's many pathogenic Th1 cells, and these Th1 cells has secreting a lot of GM-CSF. And the GM-CSF is a dangerous signal and the upstream of IL-6. So it alarms us of this phenomenon. And as expected, we also find there are a lot of inflammatory monocytes. And this inflammatory monocyte in peripheral blood, without any re-stimulation, you can find a large amount of IL-6 secreting. So at the same time, the pathogenic Th1 cells and this monocyte are significant decrease in their number and percentage in very severe COVID-19 patients. So we hypothesize these cells will travel into the lung. We also analysis the lung tissues, and you can find there are quite a lot of macrophage infiltrated there and secreting a lot of IL-6. And the result is there quite a lot of mucus secreting in the lung, which will inhibit the oxygen exchange and let the patient very hard to breathe. So all of this will lead an immune disorder in severe COVID-19 patient. So when we thought about this, we think that GM-CSF and IL-6 will be the ideal target to inhibit the cytokine storm. And at that time, there's no marketed GM-CSF molecular antibody. So we choose the tocilizumab, which has been marketed for many years and has shown its safety in the autoimmune disease. It can block not only the membrane receptor, but also the soluble IL-6 receptor. And with this medicine, we treated the first small-scale clinical trial of 21 patients, which have been diagnosed as severe or critical COVID-19 between the February the 5th and February the 14th, 2020. What we found is all of the patients within the 24 hours, the temperature will return to normal and all other symptoms will improve remarkably, including that they have lower oxygen intake in 75% within 5 days, and one patient in no oxygen therapy. And if you do the CT scan, you can see their lung opacity absorbed in 19 patients. And also the percentage of lymphocyte in peripheral blood, which previously very low in the majority of patients, will return to normal after the therapy. And another very important C-reactive protein, which previously very high level, decreased significant after this therapy. And we did not observe very obvious side effect of this therapy. And we found that 19 patients were discharged within 2 weeks, and another 2, which in very critical EU in ICU treatment, they are discharged later. So all of the patients have discharged right now. And you can see that our basic data, you can see that before this treatment, the CT scan showed they are very severe the lung disease, but after that, there is significant remission in both lungs in majority of the patient. And also, this is what I talk about, the CRP is significant decrease. Also, the temperature is decreased, and the concentration of oxygen inhalation and SpO2 will clearly removed of this patient. So after we know this in our Anhui province, we quickly share our experience to the rest of the cities in China. So now the immunotherapy strategy about the tocilizumab treatment has been included in the diagnosis and treatment program in China, a National Health Commission. So we suggest that patient with extensive lung dilation opacity or in critical patient to use this. But before that, you have tested, they have evaluated laboratory IL-6 level. And we suggest that the first dose is 4 to 8 mg per kg. And if the patient do not have very active response, you can give him or her the additional application after 12 hours. So the mechanism dose will not exceed 800 mg. We did not recommend the patient with allergic reaction or any other active infection to use this method. So I can give you a reference list of this therapy. This is our basic research. It has been published, and the 21 patient small clinical trial will impress in PNAS. And we have invited to write a commentary to talk about why and how this treatment could be effective for COVID-19 patient. And after several communications with Italy and US, several different research groups, we have some kind of consensus and published an article in there with the title of this. We also made a cartoon movie to introduce this treatment to the wide research group, and you can find it in the YouTube. So this treatment actually, after we did in China, the Italy is the first to adopt this treatment, and they quickly use in several kind of group patient in their cities. First in Nablus and then spread to other cities. And now the Italy has announced to have the clinical trial to try whether it is work or not. And at the same time, US tried 2 different antibody towards IL-6 receptor. One is the tocilizumab, similar as us, and another is another molecular antibody. So in all, it has been accepted in the scientific field that the cytokine release storm or symptom actually exists in severe COVID-19, which has been published recently by Carl June, because he's very familiar with this phenomena in the CAR T, right? CAR T therapy. And you can see that the 3 kind of molecular antibody that have been marketed are all getting to test in the COVID-19 patient. And this question is I always be asked is the tocilizumab treatment what is advantage towards the steroids, which is usually used in the quite a lot of autoimmune disease. What I want to say is because the trastuzumab is only stop the IL-6 inhibitor, it is stop the pathway connect IL-6, and it just cut down the cytokine storm, the link, right? But if you use the wide inhibitory the medicine like the steroid, it will widely inhibit quite a lot of immune response, not only the macrophage but also the CD4 or CD8 positive T cells and all of other the antivirus cytokines. So it will be inhibited in a large range and have a high risk to conduct antivirus very effectively. So this is my share dose of this. Thank you very much.
That's great. Thanks for the overview. So in terms of the clinical practice, is your team going to do a larger trials to confirm the 21 patient that was successfully completed?
Yes, the 21 patients have completed, and we try another almost 500 patients in Wuhan City.
Okay, and then you mentioned that this is the relevance is for severe COVID patients, but we know the cytokine storm can also happen in the sort of an early onset of activation. Is that a larger trial is going to look at the interleukin-6 elevation regardless of the stage of the disease?
You mean which stage of the disease could use this method?
Yeah.
We, in our experience of the 500 patients, we think we should use this method as early as possible. That means when you find the symptom of the cytokine storm, you better to use it. What we do is, if the patient is have fever for more than 3 days, we will check the concentration of IL-6. If the IL-6 is reach the level of 20 pg per millimeters, that is almost 5 times of the normal level of IL-6 in the human body, we just use it. And in this way, we will prevent the person from the mild and moderate to the severe disease.
Yeah. More like a preventive measures, absolutely.
Okay. Dr. Fu, I was just going to follow up with maybe when the 500 patient study to be released. I know in the United States right now, there's actually a nationwide shortage of tocilizumab based on really your paper, and everyone's using it. From what I understand, I don't know if it's been like this huge thing where we're getting patients off ventilators, quite like you saw. So I'm just kind of curious what your thoughts are on maybe the differences. I also am not sure if you saw a paper from Italy with Cytokine, which is just an IL-6 antibody, not the IL-6 receptor, and that those patients were on ventilators and there wasn't a significant improvement. So I'm just kind of curious what you think the differences are that everyone's seeing.
You mean except the IL-6 because it's still there's not enough supply, right? Except the IL-6, any other kind of antibody could be used. Is that your question?
I think my question was, I think everyone's around the world is based on your paper is using tocilizumab to try to get patients off ventilators, and we have a shortage of that drug here. And from what I know, though, I don't think we're getting the same results that you were getting in your study. I think it was like almost everyone was able to be extubated, if I understand, removed from the ventilator. So I'm just kind of curious what you think the differences are. I know there was a study in Italy where they did a similar IL-6 antibody and they didn't see the same effect of patients on ventilators.
Well, I have connected with the Italy group, and they are doing this clinical trial. But I did not see the whole result because we did not finish it. Yes, because quite a lot of people doing this IL-6 antibodies, so there's not enough supply of this IL-6. So there's a lot of people try other antibody to block the cytokine storm, like the IL-1, the molecular antibody, or the TNF-alpha and the GM-CSF. Yeah, but I did not see what you mentioned because yeah, they did not finish it. I'm not cannot make a conclusion then.
Just my thought on that, in order to sort of better to narrow down on the variation of the clinical data, I'm wondering that whether we can dive deeper into the samples you have prospectively and look at the more cytokine profile of the ones that are not mentioned here. So, because I think just having the eye on the interleukin-6 may not be adequate, because these patient populations are very heterogeneous. And obviously it was a very small patient population of the 21. Yeah. So my question was whether the inhibition or modulation of interleukin-6 will have any effect in other cytokine profile of the patients. And based on that variation, we're able to look at apple to apples as opposed to just laser focus on interleukin-6, because that obviously may give some variation on the clinical data, as Dr. Cruz has alluded to.
Yes, actually we have do the single cell sequence data to compare the before and after the tocilizumab treatment. So except IL-6, they are increased a lot of cytokines like IL-1 and TGF-beta and GM-CSF. And I know there are several groups in of the world have tried several kinds of inhibitor receptors. So there's several kinds of you can choose this. I know that GM-CSF have been shown be in a small scale of clinical trial to work in Italy, and IL-1 I think is another ideal target. But I do not suggest the JAK inhibitor. I know somebody are try that, because the JAK inhibitor will widely suppress a lot of pathways, including the interferon alpha pathway. And then, you know, interferon alpha is the main pathway to inhibit virus. So I do not suggest the JAK inhibitor and other pathway that will widely suppress the immune response. Yeah.
Yeah. Very good.
Is there any other doctors, sorry, from the Chinese side who would like to add on that, or we can go to other questions? Yes, Mr. Babet, yeah, you can proceed with your next question.
Great. Okay, so we're going to move on. Thank you, Dr. Fu, for the good discussion on the cytokine storm. So the next topic we want to talk about is the convalescent plasma, the antibody therapy, the merit for that. So the experiences that the colleagues around the table have on the convalescent plasma and the antibody titers from the COVID-19 recovered patients. And then what are the limitations? And that will take us more into diving deeper into a more sort of a synthetic and recombinant antibody therapies. And we will conclude with that topic.
Sure. So do you have any questions on that front? You can raise
well, I mean, just to, again, put into sort of a context, it is the next best thing in terms of having an antibody therapy, because the companies like ourselves, we're not obviously prepared to be out there with the drugs that we have specifically targeted for COVID-19. So right now, the convalescent plasma is a viable option. They're using hyperimmunoglobulin in terms of a stockpile of a frozen one. A couple of limitations that we see is the variation in the titers and the sort of the robustness or the quality of the antibody from one patient to another. And also the serological testing is very limited to be able to do a widespread testing on these patients and handling the logistics between the donors, the clinical institution that can administer that, accessing the patients, and the regulatory body that have an oversight to ensure that these are done in a safe and correct manner. So these are some of the limitations. I know in Canada, the blood bank is putting a very massive 1,000 patient trials. Some of the colleagues perhaps on the panel are involved in the patient recruitment. But our line of work is not really involved in convalescent plasma per se, but we're tapping into this type of antibody repertoire for the selection of the right antibody from those patients and modification and having a very more systematic approach of treating patients. So maybe I open the floor to colleagues that they're using that in their practice and any experiences they can share with the panel.
Mm-hmm. Thank you. So maybe Dr. Pan or Dr. Shan, do you have any idea or do you have any opinion on this antibody therapy, which was mentioned by Mr. Babet? Do you have anything to share on that front?
Yeah.
Okay, thank you. I try my best to introduce or share some experience about using the convalescent plasma. As you mentioned, the convalescent plasma is effective according to our experience and according to the report from influenza or the Ebola. I think it's effective for treatment of COVID-19. And some papers recently published by PNS or other journals, such as JAMA, give us some clues for this phenomenon. However, these reports, the sample size is too small to give a strong evidence. But according the experience and these papers, I think is effective for the COVID-19 treatment. But there is some point we should pay much attention. So if we use according to the National Health Commission, issue the guideline for the convalescent plasma treatment, we should use the convalescent plasma in 3 weeks from onset of symptom, and we should choose the severe or critical ill patients for use this plasma. And there are some limitations when we use this plasma because the complex is complex. Because first we should find a population of donors who have recovered from the disease and can donate the convalescent serum. Then we must have blood banking facilities to process the serum donation. And next, we must make an assay for such as serological assay to detect SARS-CoV-2 in serum or plasma, and virological assay to measure the neutralization. So we also need the virological laboratory support to perform this assay. In addition, there are also a theoretical risk involves the phenomenon of antibody-dependent enhancement of infection. However, we didn't observe these effects in clinical practice. So I think, yes, in a word, I think convalescent plasma is also a choice because we have not any other drugs for treatment for kill the COVID-19 virus. But we can get the convalescent plasma as soon as possible. And
very good. Thank you.
Okay.
So couple of quick questions. Do you
sorry,
concentrate?
Mr. Rebay, before you ask next, and Dr. Pan, you also have something to add, right? Please go ahead. Sorry for that.
For within my provinces, only 1 to 2 patients receive convalescent plasma. And from immunological therapy, we routinely use the immunoglobulins in the early stage. In fact, it's only 2 cases used in the later stage use the convalescent plasma. So I think I can conclude from that the plasma convalescent is very effective. So just a few cases.
Yes, Mr. Rebay. What was that?
Do you concentrate the plasma to get the right titer, the right concentration before you administer that?
So the question I think should be answered by Professor Shan Yu. You see, more samples
Okay. Yeah, I think the titers of the convalescent plasma, the titer of the neutralization antibody is a very important question. Before we use this plasma, we must test or make an assay for this convalescent plasma and make a confirmation that the titer is above as high as 1 to 1,000. Maybe better than 1 to, such as 1 to 640. So if the titer is very low, so this convalescent plasma is not any effect for the treatment.
I had a question for Dr. Shang. So as you were mentioning, there's only been 15 patients, I think. There was a study in maybe JAMA and then PNAS. And what's interesting is the patients who are getting it actually do have high titer antibodies. A lot of them were severe, already 3 weeks in the symptoms. And by then you actually do have quite a high level IgG response. So I'm just wondering, what do you think we're doing? Is the only thing I can think of is if the recovered plasma or IgG are somehow intrinsically better than the neutralizing antibodies that the severe patients have. But I think that part's kind of a mystery, and it kind of relates to the original Hong Kong study in 2003, 2004, where maybe when they give the plasma after day 14 of symptoms, it didn't seem to help patients.
Okay, I think you mentioned a very important question. In my opinion, we should use the plasma as soon as possible, or as early as possible. If we use the plasma such as 3 weeks later from onset of symptoms, then our body will produce the antibody. So the titer of antibody in our blood, in our body, may be higher than the convalescent plasma infusion. So we, in my opinion, we should use as soon as possible in the early stage of the COVID-19 happens. I think it is important. So I mentioned the paper, 5 patients published in JAMA. This is a clinical trial just without any control. This report suggests that these 5 patients used the convalescent plasma in 10 days from onset of symptom. And another paper is published in the PNS, then also used the plasma about 2 weeks from onset of the symptom of cough and fever. So I think we should use the convalescent plasma as early as possible. Don't delay to use it, because at a later stage, our body will produce the antibody.
Correct.
Okay, thank you, Dr. Shan. So Dr. Aurora and Dr. Christodoulou, do you have any questions?
Hi, good evening. Again, I'll speak as a non-inflammation non-hematology expert, more from the cardiac surgery side and from the ICU side. My question is really around two practical issues. So one, you mentioned in patients with severe respiratory illnesses of giving it early. What defines early? So when you first have fever in the first 24 hours, or the first time when they have shortness of breath, what does that timing look like? Then second, the range that you had of 4 to 8 milligrams per kilogram, is it one possible way to give a large dose up front, or to give like a 4 milligram dose followed by a second dose sometime there afterwards?
So maybe we can start with Dr. Shan. So first of all, maybe you can give us a clearer definition about the early, when you said early stage, how early is it? And then maybe other doctors can add their information. Dr. Shan.
Yeah, I think the problem is very difficult for me to answer. According to the National Health Commission guideline for the use of the convalescent plasma, we should use it in 3 weeks. We should use it in 3 weeks. So I think maybe 3 weeks is the period. I think we should carry out a more clinical trial to test this time window. So
the 3 weeks, what about the symptoms? Like as Dr. Aurora said, high fever, is there any symptoms that really make us decide when to use it? Some of the really evident symptoms.
Like in 3 weeks. So at the early stage, we use it. It's not effective. So I think it should be used as early as possible. I just want to say that. Okay.
Dr. Pan.
Professor Shan said just about the convalescent plasma. As for tocilizumab, interleukin-6 and agonist, we see how to define the early stage. We think if the patient with high fever, just said from the slide, fever for continuous for 3 days, and we say in COVID-19 patients, the patient condition may be deteriorate within 7 to 10 days. So before that, I think is the early stage. We can't define the which day, but if with patient with continuous fever and from the CT scan, we see more infiltration opacities were found in the CT scan, and the patient with deteriorate and PO2. So I think the patient may be receive the tocilizumab immediately. That's the best time.
In those patients where you've seen an effect, how soon after you started dosing were you seeing effects on those? Again, limited number of patients, I realize, of only 21 in your series.
Yeah.
When did you start seeing improvement in those who improved? And were there some who did not show improvement? What was different about those patients? Or is it just too early to tell?
Yeah. In fact, it surely is a little sample size. We need further exploration about more patients, whether it's very effective and what is the early stage.
Dr. Wei, I saw you keep nodding when Dr. Pan was speaking. So do you agree with Dr. Pan? Sorry, you have turn on your audio. We can't hear you. Still sorry, we can't hear you. Maybe we'll get back to you later and you can fix your audio. And also maybe our technician can help you with that. So I'm sorry. So maybe we can go to Dr. Christodoulou. So Dr. Christodoulou, so what's your question?
Yeah, thank you very much. I'm a cardiac anesthesiologist and the head of anesthesia. My question relates to post-operative presentations of cytokine storms. We know from a paper published in The Lancet in early March of 34 patients. They were again from Wuhan. There was a 20% mortality rate for patients presenting with COVID-19 in the post-operative period, typically between day 2 and day 5. And 20% of those went on to die, and 44% ended up in ICU. Do we have any experience of the use of tocilizumab or convalescent plasma in post-operative patients that manifest after surgery? Do we have any clinical experience of using the drug or the plasma in post-operative patients that came in without symptoms, that developed COVID post-operatively?
So who can answer that question?
Well, do you mean that this patient do not have any symptom and you give them plasma, Is that what you mean?
No, these patients would have come in to have urgent surgery, cancer or otherwise, and then they developed COVID. They presented with fever, cough on the 2nd to the 5th postoperative day. Have any of those patients received tocilizumab or convalescent plasma? Do we have any experience of the use of the drug or the plasma in a COVID positive patient that's presented after surgery? That's the question.
I don't have any experience with that, Dr. Chris Gadulu. I can say, though, that at my hospital, kind of on this unique scenario, we're starting to test all asymptomatic patients going into surgery. I think the effort was really around the epidemiology of having PPE and protective measures for the OR and anesthesia. But it would certainly combat the scenario that you're mentioning, where these asymptomatic patients get surgery and then start to develop their COVID symptoms. So I'd imagine then that could be a measure maybe worldwide that could be adopted to prevent this kind of serious scenario that you're describing.
Yeah, I mean, it's very concerning, and the paper really speaks to the fact that, if you miss the individuals during the testing window, if you're going to screen them, and you're only going to go on whether it's nasopharyngeal or, serum PCR, then there's going to be a subset go ahead with urgent surgery, and you don't know manifest post-op. But it would be fascinating to know if the drugs work in the post-operative period, or if convalescent plasma is an option, at least at that point, if they manifest 48, 72 hours after surgery. I'd be very interested to know if it's efficacious in that setting. Thank you.
Okay, thank you. So, and Dr. Qin, I know you're conducting a research, especially on the antibody of COVID-19, right? So can you share with us briefly about your research and the process, how's it going so far? Professor Qin, yes. And before you talking, you need to turn on the audio. Thank you.
Okay, can you hear me?
Yes.
Okay.
Now.
Okay. Thanks for the CNTV for inviting me to share my research experience. I'm a research scientist, and I would like to thank these frontline medical doctors for their contribution to combat this COVID-19. And I think later on, maybe I can discuss more deeply with Dr. Said Babay with this recombinant antibodies, our strategies, how to develop novel recombinant antibodies. And so far, I think according to what I learned from my colleagues, I think this serum from the covalent patients, they might be useful, but so far we only have like a few cases, and it's too early to get a conclusion yet. Okay.
Okay, thank you. So because now for some of the international guests, we might not hear your questions very clearly. So now I would like to suggest we bring in with the help of the translator. It's only for translating the questions. 因为我们可能有的时候音频有点问题，所以我们国际专家的问题，其实我们在这个中方听的不是特别清楚，所以现在我们就建议我们引入一名翻译吧，这样是把外方的问题帮我们翻译一下。可以更加精他们的这个提问的点，各位中方老师觉得可以吗？ So, okay, let me check with my technician. Is the translator ready now? Can we proceed? Okay, maybe we'll just proceed and I will let you know when they are ready. So maybe we can have, so Mr. Babay, you have more questions, right? You can, yeah, please go ahead.
I was leading to sort of the last topic for the interest of time. We have 15 minutes on discussion on the use of the recombinant antibody. This is a good segue talking about antibodies coming from the convalescent plasma into having a targeted and a clean antibody that is specific for COVID-19. So I can share very briefly about our experiences, how we're going about this, and certainly we look forward to collaboration with various colleagues, with Dr. Pin and others. So at Virotech, the way we look at the recombinant antibody approach is building a library of a very massive library in the range of the billions of antibody through immunization of camelid. So our technology is a single domain antibody, VHH or camelid antibody approach, that where we immunize the llamas. We build a very large library in the range of the billions. And from there, it's really picking up the needle out of the haystack, where we really select a very short list of antibody out of a large repertoire, as I mentioned. We deploy a very advanced artificial intelligence and machine learning that is surrounding the targets of interest. So the targets are available in the context of COVID-19. It varies, and you have different scientists and groups, and Dr. Cruz can talk about his experiences on the targets that he has selected. At Virotech, we're interested in neutralizing the virus itself, and we're looking at the spike protein, a very specific part of the S protein that allows the attachment to angiotensin converting enzyme, the ACE2. So that's our strategy, is a neutralization, something that we have done in the case of the foodborne pathogen and outbreaks, where we actually neutralize the bacterial infection in production animal. We're deploying a similar strategy for COVID-19, but other possibility includes a modulation of ACE2, some in the area that Dr. Cruz is working on, and using modalities to actually interfere with proteases that is involved in the elliptic cycle of the virus. And there's a couple of protease targets within that as well. In terms of the modality, there are monoclonal antibody approach. Within that, we have a number of companies that they're using a cocktail of antibody, because you have to be mindful of blocking the various epitope of the target. So within the S protein, there are at least 2 epitopes that allows the entry to the cell, the ACE2 attachment. In our case, we're one of the very few company, and the teams have the capability of developing a bi-specific antibody. So these are a single drug and a single molecule with dual functioning capability. We're binding to the both epitope at the same time, as opposed to using a cocktail of the drugs, where it causes the problem potentially from the production and the scale up. And we know in a pandemic situation, scale up and production accessibility of the patients around the globe is a major important topic and a concern. So our single drug function, it can be a very attractive and elegant way of neutralizing the virus and enabling the attachment to the cells. So I'll stop there for now, and then maybe I'll pass it on to Dr. Cruz about his experiences on other targets and strategies that he's utilizing with his collaborator. Dr. Cruz, to you.
Sure. Yeah, so I think there's a lot of hope for recombinant antibodies, certainly to pass from the convalescent plasma for the next few months. Really, there's a few companies in the US right now developing it. Most of them are the cocktail approaches that Dr. Bay talked about. I'm also working with a number of companies on what's called a receptor decoy, where you'd actually use the ACE2 itself as a soluble molecule, so it's not bound to the cell surface, and it could similarly bind to the spike protein. Another name for this strategy are called immunoadhesins. So the ACE2 would be bound to an FC receptor. So it's very similar to some of the monoclonal antibodies also being created to that same ACE2 binding site, except you're using the ACE2 itself. There are certain pros and cons to this. Certainly, we know a lot more about making monoclonal antibodies than we do about immunoadhesins, but there's been a couple of reports, one from China, and I think another from Florida recently, showing efficient neutralization by an ACE2 FC. So I think that's promising, certainly the monoclonals, and as long as one of these strategies works, they can hopefully be used. There's been a lot of discussion today. I think that's the broader consensus, that we need treatment early on during the infection when patients come to the hospital. So whether it's an antibody or possibly an immunomodulator. Hopefully, if it's an antibody, we won't need the immunomodulator to really rid the virus. But I think the companies I've talked to, they're all working as fast as possible. But unfortunately, probably the monoclonals will be ready later this summer. So we'll see what the pandemic situation is at that time.
Okay, thank you, Dr. Cruz. So now let's take a short break from our expert discussion and take a look at the big screen to see what are the questions and comments from our followers. We have got hundreds of them now. Now we have picked 3. And now how about let's take a look at the second one. So is it from Facebook? It said, is it hard for people having diabetes compared to normal person? I suppose they're asking for those people who are infections of COVID-19. So is it hard for them to recover, especially with diabetes, compared to normal people? So who can ask that? Who can answer that question? Dr. Pan or Dr. Sean? Do you have any experience? Do you have treat any patients with diabetes maybe at the front line?
Yeah. We see that diabetes is really a high risk for COVID-19 patients. We see, and the most important characteristics of such patient is to difficult to control the glucose of the glycemia, and the blood glucose is very high and resistant to insulin therapy. So these patients we see not only to limit their intake, but also with intensive insulin therapy and with the long terms. But from other point, and just from this, but for other parameters, I think it's just the same as the normal patient. Yes.
Okay, thank you, Dr. Pan. Let's take a look at the third question. It's also from Facebook. So it's, what is plasma treatment means, and is it best now? Maybe Dr. Sean or Dr. Fu, who can answer that. Is plasma treatment the best now, and what does it really mean?
Okay, do you mean the best treatment choice?
Yes.
Oh, yeah.
Is it, or one of them? Because it's by our follower who's now watching our show. Yes. Go ahead, Dr. Sean.
Sorry, I just see the screen of the Dr. Pan. I didn't see any questions or list. So just mentioned, there is not any approved drugs for the treatment of the COVID-19 virus or SARS-CoV-2. But we can use, we try to use some drugs mentioned by the literature, such as Leponavir and we such as Leponavir and chloroquine. But I'm not sure these drugs is effective as we hoped. So another choice I think is we just talked about convalescent plasma. We should use as early as possible. And in the another side of the treatment is the anti-inflammatory response, anti-inflammatory treatment, such as interleukin-6 antagonist. So if this drug is not widely used in some country or is shortage, so maybe we could choose the corticosteroid. As mentioned by many papers, that corticosteroid has some shortcomings and adverse effects, but I think is easily to get. So we maybe to choose. But as a critical or severe situation of the COVID-19, This patient must admit to ICU immediately and accept the critical care. And at the same time, we must use the etiological treatment at the same time. So I think the both sides, supportive care and the etiological care is both important.
Okay, thank
so
you.
I just want to say, okay, I'm stop here.
Okay, thank you, Dr. Shan. Any other doctors who would like to add on that?
I would like to add some comments. That
Yes,
although that plasma treatment have been proved some kind of effective, I think it could not replace the vaccine. So we just all the world are waiting for the vaccine, because you give the patient the plasma transfer is just a passive immunology. That means you give somebody's others antibody. And when you give them, they can antivirus. But if you do not give them, they still get affected risk. So only the vaccine can help the bodies safely to get their own protective immunity. So they could not replace. Okay, I'm over. Yeah.
Thank you. Dr. Aurora, do you have more questions for our experts? Please go ahead. And also now, just to mention that we already have the interpreter coming in, so we'll have that translated after Dr. Aurora's question. And also for our Chinese experts, if there's anything that they think is better expressed, it will be better expressed in Chinese. So you can just feel free to say Chinese, and then we can help them translate into English. So English or Chinese, you can choose either. Yes, please go ahead, Dr. Aurora.
Okay. Again, my question's coming from a non-immunology or inflammatory perspective, but for the patients of whom we've treated with either convalescent plasma or with the IL-6 inhibitors, are you seeing any differences with regards to microthrombosis? That's been one of the progenitors of what we think is causing significant pulmonary difficulties in our patients.
Translator, please. We can't hear you. You have to turn on the audio before you speak. Thank you. Now it's good.
对于我们在这个使用恢复期血浆或者是sorry。不好意思，我再重复一遍。对于我们使用恢复期血浆和类固醇，就是糖皮质激素 steroid 这两种疗法来比的话，大家会发现在疗效上有什么样的不同呢？比如说哪一种会有更多的一些肺部微小血栓的出现，或者是其他的一些在这个治疗之后病人的特征上有什么样的一些区别呢？谢谢。
So who can answer that question?
I may start. That I think these two therapies are different because you give them plasma therapy. The target is antivirus. So as the several of our experts has mentioned, it will give them when they get included as not, and you could not give them very late. So it could help the patient to antivirus. But the tocilizumab, this therapy is only given to the patient that have the symptom to become cytokine storm. That will be very severe or critical patient. So the patient use it is different. Okay, and the target is different. So the target, one is to antivirus and one is to stall, to regulate the immune response.
Our interpreter, please turn off your audio when you don't speak. We can still hear you. Yes, great. So any other doctors from Chinese side can add on that? Okay, so Dr. Chris Dulo, do you have more questions?
No, thank you for the opportunity to participate. I appreciate all the work that's ongoing.
Thank you. So our other international guests, Mr. Babay. Please go ahead.
I just want to add, since we talked about the vaccines, so here we're not talking about with the recombinant antibody in terms of any replacement for the vaccine. I totally concur with Dr. Fu's assessment and comment that the vaccine obviously is the one that provides an active immunity. So in the context of a recombinant antibody, we're talking about two patients or two opportunities that the vaccine may not really be appropriate. Or one is obviously the healthcare provider front and first responders that they're not going to be taking a therapeutic vaccine. If we're talking about the preventive vaccine, that's a whole different situation. But right now, most of the efforts are surrounding therapeutic vaccine, where now you have COVID-19. So for the healthcare providers, what we're proposing is a prophylactic use of recombinant antibody, where you will have a protection during the shifts that you're providing for a series of hours, a day or two. And then on the more extreme case of things, when you're immunocompromised and your immune system is significantly suppressed, then the chance of the vaccine is going to be significantly minimal or non-existent. And then I think one of the defense that you have is a recombinant antibody approach. So that's one comment. And the second one is the route that these antibodies can be given. It can be very much efficacious and appropriate getting right to your lung as opposed to giving intravenously in a systemic use. So for example, the technology we're using through nebulizer, it really allows you to get neutralization right in the lungs, as opposed to some of the antibody modalities that requires a systemic high elevation in your body in order to reach the lung, and it does what it's supposed to do. So I just want to sort of make that comment, and if there's anything I want to follow up on that, please go ahead.
Sure. So any other doctors, Dr. Cruz or Dr. Rora, do we have more questions?
Yeah, just to piggyback, clearly a vaccine is the goal of the field, and hopefully we'll have one available in the next 12 to 18 months. What was really interesting was that recent study from Shanghai, though, where they found a decent portion of people who had COVID-19 never developed an antibody response. Of course, these patients were 40 and younger, and they did recover. So that could have something to do with the immunological phenomenon and the kind of the older prevalence for mortality that we're observing. But it does kind of put the intriguing question forward is how well will people actually respond to a vaccine, and if a significant portion, or even if that's like 15%, don't ever make titers to a vaccine, then certainly having recombinant antibodies for these individuals as a therapy could be very useful.
So our translator, can you help us translate that question? The one about vaccine. Do we still have you? Could you speak a little bit louder, please? We can't really hear you. Sorry for that. Yes, go ahead, please. There might be some audio question with our interpreter. So Dr. Pan, can you answer the question about the vaccine and also like the different reactions of patients with vaccine?
Yeah, I'm just a doctor. I'm not an expert on vaccine or immunology. I only can say is, as for this virus, and lots of things we should explore. We can fully understand or fully know about this virus.
So any other doctors, maybe Professor Chin or Professor Fu, do you have any other comments on that, the vaccine?
Yeah, I totally agree with you, Robert, that this virus, as Dr. Pan has mentioned, is a new coronavirus. There's so many things we don't know, that there are many evidence very strange. Because, for example, there's people have no symptom from the beginning to the end. And now we also find some people can re-exam the positive after they discharged. So there are also people that could not have antibody after infection. So they are all evidence, but we do not know the mechanism behind. And the virus is very kind of that. And the similar phenomena has also been observed, like the HBV. I know some people have injected HBV virus, but they could not find antibody secretion. There's some kind of population that like that. So as scientists, we should do more work to do that, right? I just comment about that.
Yes,
Okay.
can you hear me? I think I totally agree with Doctors Pan, Doctors Fu. At this stage, we lack many knowledges about this virus. And I think it's curious, for example, for many cases, I know there are many cases, their effective rate are very low. And I think we currently in China or in Wuhan or in Hubei province, we don't really take like serological tests for the antibody titers in their blood. So I think for this issue, we still need many things to further explore. Okay.
Right, we still need more time and more experience to give a sound scientific conclusion, right? And now I think we are finally have Dr. Wei with the audio working. And Dr. Wei, because we haven't talked to you throughout our live streaming, so maybe not on vaccine because you're a chief physician at the Department of Radiology at your hospital. So throughout this process of treating patients with COVID-19, do you have any experience, something expertise to share with our experts from other countries? Please go ahead. You need to turn on your audio.
Okay.
Yes, thank you. Yes, now you can talk, yes. Now you turn it off.
Oh.
No, it's not working.
Thank you.
Now it's good.
Thank you. I think chest CT is an important role in the diagnosis.
We still can't hear you. Dr. Wei, we still can't hear you clearly. Do you have a microphone?
To operate and can provide fast diagnosis and assessment of COVID-19. The rapid and accurate prediction of severity is of great importance that could help the estimation of the ICU event or clinical decision of treatment planning. Thank you.
Okay, thank you, Dr. Wei. And now let's take a look at the big screen. We have more questions coming from our viewers and followers on social platforms. Now let's take a look at the big screen to see the questions. Okay, so let's take a look at the second one. Donors of plasma may be challenged. So I guess the question, is it a challenge for the donors to give out plasma? Is that a challenge for maybe, no? Dr. Pan, do you think it's a challenge for the donors to give out plasma?
I don't think it's a challenge for the donors because we just got nearly about 400 milliliters of plasma. So I don't think it's a big harm or some little harm to the patient for such patient.
What about Dr. Cruz and Mr. Rabe? Do you have any other ideas on that? Do you think it's a challenge for donors to give out their plasma?
So I practice transfusion medicine in the United States. So for us, we're having the same requirements as normal donors for the recovered patients. So to a certain extent, that might exclude some donors who would otherwise have wanted, to give plasma, but are excluded. But in general, it's a very safe procedure. It circulates blood out of your body with apheresis, returning your red cells, and most people tolerate it really well.
Okay. Any other opinion on that issue? Great. Let's take a look at.
I can share. Sorry.
Yes.
I can share
No,
the
Dr. Shan.
appearance
Yes,
from.
thank you.
Yeah, I can
Go
share
ahead.
the appearance from Wuhan. So we will give advice or mobilize the recovery patients from COVID-19. And we hope they can donate their plasma for the treatment. Many more patients suffered from COVID-19. So then we get the convalescent plasma. If we don't do this, then we can't get it. So we choose the young and stronger patients from the young and strong recovery patients. So we get more and more convalescent plasma. Okay, this is the Wuhan experience.
Oh, okay. And also, let's take a look at another question from our followers, the third one. So how does UVC light impact the microbial profile? Is there an impact from UVC light on the microbial profile? Can any of our experts answer question on that? Yeah, it's a little bit confusing, right? If you have no comments on that, we can just go to the last round from our international experts. So Mr. Babay and Dr. Cruz, before we wrap up, do you have more questions?
I think I'll be personally interested for Dr. Chin if he can comment on his antibody strategy. We didn't get a chance to hear from him the modality and the strategy that he's adopting to develop a recombinant antibody. So if you can maybe speak to us at a very high level briefly, that would be great.
Okay, thank you for asking me. I think our strategy isn't different from any molecular scientists all over the world. So basically, we're trying to PCR cloning the encoding sequence of this IgG heavy chain and light chain, the CDR region, and then we clone them into expression vectors. Then we express this in the many expression systems. That's what our strategy. And we got donor the peripheral blood cells, and we isolate this the monoclonal B cell memory B cells, and then we trying to PCR cloning these encoding sequences. I think that strategy is very similar all over the world. Every molecular scientists may be familiar with it, but I do have a comment on the discussion you earlier you mentioned. That's your strategy to make the replace therapy for the covalent plasma. So you mentioned now you have like three strategies. First, you immunize like llamas to get antibodies. Second, you trying to develop some protease inhibitor targets. And third, like what we do to develop some monoclonal antibodies. So is there any so I read a paper from Harvard University. They develop like the short peptides which can block the interface between the spike protein RBD and ACE2 receptors. However, we tested a little bit on that peptide, and according to what they reported, the KD value was pretty low, around nanomolars. But however, we tested it's not working on our cell-based assays. Anyway, but we still one of my colleagues he developed like around 24 peptides, like small library based on these interface structures. So now we're testing if our small library of peptides can inhibit or block the interaction between this RBD and ACE2 receptors. Okay, that's my experience.
Thank you. Just a quick comment on our experiences in other contexts for immuno-oncology or other diseases that the peptides, you can show some efficacy in vitro models or sort of a very defined cellular model. but their efficacy in vivo, even in animal model, often has been questionable and is not really translatable. The concern that we find when you develop an antibody is considered the raw material, right? Is your active ingredient, but we're more concerned on the product development, the production, and the expression of these peptides. It doesn't really pan out. And that's why we moved away from a peptide biology. I'm sure it has merit in some incidents, but in this context, we're looking into full-fledged robust antibody that has been proven in a similar fashion. And now the eye is on what are really the golden target associated with COVID-19.
Okay, thanks for your comment.
Dr. Cruz, you have any comment on this before we move on?
Mm-hmm.
I also that paper from MIT Harvard. I think it just has to deal with the stability, perhaps, of the peptide.
Yeah.
And yeah, I think the challenge in general from a big picture is all the research are preprints right now. So they're not peer reviewed. People are rushing out as fast as possible.
Yeah.
Obviously, that's really helpful, but a lot of the science also might not work or be reproducible. So
correct.
Right. One of our strategies is to stabilize this different peptides by introducing like sulfide bonds or other like the chemical modifications.
You mean disulfide bonds, right? Disulfide bonds? Yeah,
right.
Absolutely. Yeah. And what systems do you use for production? Are you still using mammalian systems like CHO cells?
Yes, we use mammalian cells.
Okay. Yeah, thank you.
Thank you.
Thank you. So before we wrap up, Dr. Pan or any other Dr. Shang or other doctors and professors, do you have more to share or to say?
Yeah, from the clinical point, I think for COVID-19 patients, and most important, although lots of strategies are to explore for these patients, and most important of all is the basic therapy is a supportive therapy. So the most is for hypoxemia. So we see, apart from that, therapies and leukin-6 or convalescent plasma, we just to support the patient to correct the hypoxemia. That's most important. Until now, we see there's no drug is effective to antiviral. So the second is to relieve the symptoms. So from this point, and the leukin-6 can relieve the fever, can reduce the oxygen consumption. So I think the leukin-6 maybe can be explored inside the patient and can be used. And the second is other combined therapies such as nutrition, such as to anxiety relief, and also to care about the patient's psychological stress, that also are very important. That's all.
Thank you so much, Dr. Pan. Other doctors and professors, do you have more to share before we conclude today's discussion? Dr.
Okay,
Shang.
I want to say some words. As we know, we can classify the COVID-19 patients according to their syndrome or clinical manifestation. So mild, moderate, and severe and critical. So for the severe and critical patients, that we must do as talked about Dr. Pan. For one is for the etiological treatment, and another side is the supportive care. For the mild or even the moderate patients, I think a word less is more is important. So we don't use many strategy for treatment of mild or moderate patients because less is more. So we should know our body has the great immune or strong immune function to clear this virus. So for the mild or moderate COVID-19 patient, we don't do anything or just helps to observe the symptom of clinical manifestation. So this was what I want to say. Okay.
Okay, less is more. That's really a very smart summary. So about two ladies, Dr. Wei and Professor Fu, do you have more to add?
I want to ask my candidate scientist. I think it's very interesting that I observed in the New England magazine that it had been reported that in the pregnant woman, there are a lot of percentage of patients, they have indeed infected COVID-19. Their coronavirus is positive, but there are no symptoms at all. So the percentage is really high. So I think it's very interesting that there are different immune status depend whether they have symptoms to the coronavirus or not. So I wonder whether you have your opinion about that.
I had this same debate with a few people. Certainly, as you were alluding to, pregnant women have different immunological states, and that could factor into whether they have symptoms or not. I would still argue that the biggest confounder is the fact that pregnant women are in that younger than 40 group for the most part. And we know these patients have a much higher percentage of recovering. So I would argue it's likely that is why such a high percentage were asymptomatic among pregnant women. But that was found in the most recent New York serology or PCR survey, where a very high percentage of pregnant women were positive but asymptomatic.
Okay, thank you.
Thank you. So if that's it, thank you so much, everyone. And we are going to wrap up today's discussion, which is very intensive, but also very productive, in which our experts from China and also Canada and other countries have shared their ideas and thoughts on the most pressing issues such as the antibody therapy and more. So with that, we're going to wrap up today's discussion, and a big thank you to all the experts for your contribution and your time. And also thank you for our followers for your attention, and we'll have more to come in the following days. Thank you and goodbye.
Thank you.
Thank you.
Thanks.
Thank you, everyone.
Thank you.
Bye. 谢谢大家。